we have a very lengthy agenda, so we'll try to get through as quickly as possible. I know for many of you, this may be your fourth meeting for the day. Appreciate your indulgence as we go through this. So to that end, presenters, if you would, please be as concise as you possibly can be, because it's just been a long day for a lot of people. And committee members, if you have questions, again, keep those as concise as possible and limit them. And you can always have that conversation when we come back in January. To that end, start with roll call, please.
Senator Adams, Senator Berg, Senator Carroll,
Here.
Senator Douglas,
Present.
Senator Herron, Senator Mills, Senator Nemus,
Present.
Senator Rawlings,
Here.
Senator Richardson, Senator Tishner, Representative Bratcher,
Here.
Representative Bray, Representative Burke, Representative Callaway,
Present.
Representative Camuel,
Here.
Representative Dotson, Representative Duval,
Here.
Representative Fleming, Representative Gordon, Representative Holloway,
Here.
Representative Marzian, Representative Neighbors,
Here.
Representative Proctor, Representative Rayburn,
Here.
Representative Raymer,
Here.
Representative Riley, Representative Sharp, Representative Wilner, Co-Chair
Here.
Mosier,
Here, Wilner.
Mosier's here.
Chair Meredith.
Present. We do have a quorum duly constituted to do business. This is the sixth meeting of our Interim Joint Committee on Health Services. Just a reminder, as we do every committee meeting, please silence your cell phones. And not only is this the sixth meeting, this will be the last meeting for this interim session, so be aware of that. First order of business is approval of minutes. Is there a motion? Motion and a second. All those in favor say aye. Aye. Any opposition? There being none, they stand approved. Gonna have a slight change in the order of our agenda here. Want to do the regulations first because I'm quite concerned that about maintaining a quorum, and that's our last agenda item. Are there any questions or discussions about any of the presented? Seeing none, then they will be accepted. Thank you. Also, another slight change in the order of our agenda. I'm going to go to agenda item 5 because one of our presenters has a scheduling conflict. But to that end, Nancy Tate. And I believe you said Representative Nemus is joining, or is he? Yeah, we'll do that. Appreciate that. Thank you. Call you up. Obviously, he's the one that has our scheduling conflict. We'll go back to the original order of the agenda. Item number 3. This is an act relating to utilization controls for non-opioid analgesics in the Medicaid program. Senator Neal, your show. And Chad Grant. Is Chad joining you? I see Chad. Okay. If you would, you know the routine, Senator. If you identify yourself for the record.
Senator Gerald Neal, 33rd District.
And your guest?
And my guest here today is Miss Tara Mosley Hyde, CEO of People Advocating Recovery, who will actually dive deeper into the details with respect to the
Let's not
subject
dive too deep because
Well, in fact-
I've got 10 minutes committed to this presentation and I would like to make sure we.
I wanted to start out by saying I'm going to adhere to your admonition, and I'm going to make my part very brief. And
Well, I'm fond of saying this, don't give me the labor, just give me the delivery, okay?
Got you. So let me say this. Pain
you.
parity legislation is needed to ensure access to novel, non-opioid choices that would address the issues in the Commonwealth with respect to BR 1027. Pain parity safeguards equal access for patients with acute pain. Pain parity ensures equal access between opioid and non-opioid options. It levels the playing field by prohibiting the use of prior authorization or step therapy to ensure patients are not disadvantaged when accessing non-opioids. I just want to say this particular piece, and then I'm going to turn it over with respect to your admonition. Many short-acting opioids are available without prior authorization or step therapy. It is imperative that we do not place obstacles in place to access non-opioids or patients will be denied a real choice. When a patient experiences acute pain, a prior authorization is a major obstacle to access, and most prescriptions are abandoned if prior authorization is required. So generally, quantity limits are the only restrictions in place. I'm going to stop right there and turn this over to get into the subject matter and perhaps questions that will be available. Thank you, Mr. Chairman.
Hi, everyone. Tara Hyde, People Advocating Recovery. Thank you so much for hearing us today, and I will keep it brief to be respectful, obviously. I think as a person who's in long-term recovery, I've been in recovery since 2011, just over 14 years. And, the important thing for us is that we have options. And what this does is it creates an opportunity for options for individuals, regardless of what type of health insurance that you have. And if somebody is in a car accident, they don't have time to go through prior authorization to get access to a non-opioid derivative. They don't have time to go through those procedures. And so this allows for that option to be available for people, including someone like me. Now, for me, I have been benefited that I have not been in a situation like that. However, I work at an organization where I hear every day when someone has, went through some sort of traumatic incident like a car accident or sustained an injury and have to make a very tough decision of whether or not they have to take an opioid or not take an opioid to deal with a pain like from a surgery or something. And a lot of people don't, and they try to compensate. And that is so difficult for a lot of people. And some people, it can cause and exacerbate substance use disorder. So what this actually does, it prevents people from going back into a reoccurrence of substance use. So this actually helps to prevent people from going back into that chaotic use state. So I think that is an important note that we need to take in whenever we're making these decisions. And it provides, again, opportunity and access. And that's the important note that I want to leave you with.
Appreciate that. Senator Neal, I believe there's a fiscal note on this, the last session, was there not? I'm going from memory. I'm pretty sure there was, and it was, we have it in front of us here. No impact, so no fiscal impact, so thank you.
Yeah, thank you, Mr. Chairman.
Senator Berg, you have a question?
A comment, a statement very quickly. Thank you very, very, very much. I actually think we need to expand this so that when an insurance company requires step therapy for a prescription, they should have a drop-down box at the time that prescription is written so that the physician that orders it can explain why step therapy is not appropriate, and then the drug should be automatically approved. This is not just with opioids versus non-opioids. This is happening daily. Happened to me last week. I had to spend $150 out of pocket because I didn't have the time to wait for a prior authorization for a drug that was obviously contraindicated. Their first line therapy was contraindicated. If my ordering physician could have put that in the order, then they should have immediately approved that medication. Thank you.
Obviously, Senator Berg has a lot of passion about this particular subject, and I appreciate you sharing that with us, Dr. Berg. I agree with you wholeheartedly. Dr. Douglas.
Thank you,
Douglas.
thank you, Mr.
Dr.
Chairman.
Douglas.
Thank you, Mr. Chairman. I was trying not to talk, but it's
I'm
difficult.
not that lucky. Go ahead.
It is difficult for me. In simply a statement, one of the things I want to remind everyone about is that opiates really undergo a lot of research and development, and they're usually approved for very narrow windows. I'm a guy who stopped writing for opiates back in 2000. So I am not a pusher of these medications. In fact, I rail very hard when people are put on these unnecessarily. I also want to remind that we use a lot of things for off-label use. And I just want to make sure that when we're going with non-opiate medications, that we don't open up a window where we have providers starting to use these as supplement medications to the opiates that they're already writing, thus increasing the cost of care and the cost of treating. And I just think that's something we got to take a look at. Thank you very much, Mr. Chair.
Thank you, sir. Any other questions, comments? Seeing none, see you in January.
Thank you.
Thank you.
Appreciate it, Mr. Chairman and committee.
We will move on to the fourth agenda item, an act relating to physician assistants. And Senator Scott, I see that you're here, ready, available. And because you're one of my favorite senators, I've allotted 10 minutes for this presentation as well. So,
Well, ain't nothing like it the
You
same
can
amount
thank
of
me
time
later,
that you give
buddy.
Gerald. I mean, you know you're moving up when you get that kind of time. So,
please introduce yourself for the record, and as well as your guest, and proceed.
Senator Scott Maiden, Senate District 29.
Andrew Rutherford. I'm a critical care PA and chair of government affairs of the Kentucky Academy of Physician Assistants.
Thank you. This was a bill that we heard the previous session. Senator Madden is going to file this for this next session. So there'll be quite a bit of discussion about this, I'm sure, but if you would, please proceed.
Thank you, Chairman Meredith and Co-Chair Moser, for giving us the opportunity to present today. And I know I look around the room and I see several folks that have a lot of background in this. I know Representative Moser does. Senator Meredith certainly does, 35 years being a hospital administrator. Senator / Dr. Douglas, Senator / Dr. Berg. So I know this. You folks will have a lot of input on this, but and I'd be remiss if I didn't mention Senator Lindsey Tensioner, who carried this bill last session and brought it to my attention. So I got interested in this bill particularly because of the access to care in rural America, especially in eastern Kentucky and western Kentucky. You know, it's no secret, it's been going on for a long time that we have a tremendously hard time in getting physicians and docs in our area. But I want you to listen today, and this is not a doctor versus PA thing. And I feel very good today because I've met with both sides of this. I met with KMA before I came in here and also met with these folks. And they are going to sit down. Believe it or not, you can actually get things done when you sit down and try to work things out. I've had that happen a couple of times just during the interim by putting people together and put them in the room and let them talk. So I'm going to turn it over and let him give the presentation. But my whole interest in this bill is to try to see if we can possibly get some assistance for rural eastern Kentucky to get some additional physicians and PAs in our area.
Senator, I appreciate you mentioning that the Kentucky Medical Association has engaged on this. I spoke to them earlier a couple times this week, and I understand you have ongoing discussions. We know there's some concerns. There's some ongoing discussions, and hopefully we can get that ironed out before we come back in January. But again, that's how the interim session is supposed to work. We threw out these ideas, and we batted back and forth, and so I appreciate that everybody's willing to sit down and talk about it.
Yeah, we
So
had
thank you.
very good discussion today. Thank you.
Please proceed.
Thank you, Chair Meredith, Chair Mosier, and committee members for allowing me time to discuss proposed legislation that promotes healthcare and workforce development. As mentioned earlier, my name is Andrew Rutherford. I am a critical care PA and the chair of the Kentucky Academy of Physician Assistants Government Affairs Committee. I appreciate the opportunity to highlight why modernized team-based practice models for physician assistants is essential in advancing healthcare in Kentucky. As we've met with many of you all multiple times, I'm going to skip some slides that kind of talk who we are in the interest of time. So changes within the proposed legislation includes changing the current practice model from a PA physician supervisory model to a PA physician collaborative model. It will allow physicians who work directly with the PA to dictate the PA's scope of practice by allowing the scope to be delineated at the practice level, and it would allow PAs to have prescriptive authority for Schedule II medications with certain restrictions that I will discuss, and allow PAs to perform driver's license vision testing. The change to allow Schedule II prescribing for PAs will bring Kentucky in line with all of our bordering states and the vast majority of the United States. But we have written controls into the bill for Schedule II prescribing. For narcotic Schedule II controlled substances, except for hydrocodone combination products, prescriptions will be limited to a 72-hour supply, while non-narcotic Schedule II medications and hydrocodone combination products will be limited to a 30-day supply without refill. As per current statute found in KRS 218A, any prescription issued for a Schedule II controlled substance intended to treat acute pain is limited to a 3-day supply. Additionally, I do think it is important to remind this body that PAs must have at least 1 year of experience as a licensed and practicing PA before being eligible to apply for controlled substance prescribing, and the PA must then submit an application to the KBML for Controlled Substance Prescriptive Authority. This application must be signed by the PA supervising physician, and the physician can further limit which of these medications the PA can prescribe. So while this would allow Schedule II prescribing for PAs, there would be guardrails at multiple levels. The changes that PAs in Kentucky are advocating for are not novel concepts and have already been implemented in the states surrounding us. In all Kentucky's border states, scope of practice is determined at the practice level, and PAs have prescriptive authority for Schedule II controlled medications. The only border state that continues to utilize the term supervision is Ohio, while all others utilize collaborative practice models. This proposed legislation is not about seeking independent practice or creating a new innovative practice area for PAs, but about taking a step towards practical, modernized, and team-oriented healthcare that PAs and states around us practice in daily. Not only has other states embraced the concepts that we have included in our legislation, but so has the current presidential administration. The Rural Health Transformation Program, which was created by the passage of H.R. 1, is a $50 billion federal initiative that aims to strengthen rural health care by improving access, quality, and outcomes. As part of the application for this grant, the Centers for Medicare and Medicaid Services have included a section focused on practice environment for PAs. Unfortunately, due to Kentucky's restricted practice environment for PAs, the state and any entity applying from Kentucky is at a disadvantage when applying for these funds, as they will receive 0 points on this part of the application. As you see, not only has individual states moved to less restrictive practice environments, but there's a federal push to allow PAs to practice to the top of their education and training. I know there will be questions about each of the changes proposed in the legislation, so I'll move through this quickly and touch each. We believe that change to collaborative practice will strengthen team-based care, as it will reflect modern healthcare teams and how they function. Collaboration will allow each member to contribute within their training and competence. When the change was presented last year in the form of Senate Bill 88, there was concern regarding safety and quality of care. Multiple publications, including a report done by the New Hampshire legislature, an article by DePalma, and several independent research articles, they have found no evidence of patient harm when transitioning to collaborative practice. Per DePalma's article, which was published in the Journal of Medical Regulation, she discussed that allowing PAs to practice in collaboration with physicians rather than in a supervisory model had no effect on PA malpractice, but it significantly decreased the risk of malpractice for physicians. Our current statute, which is not reflective of modern healthcare practice, is adding undue liability to physicians and creating clinically unnecessary red tape that impacts patient care. A collaborative model will decrease the administrative burden felt by physicians, clinics, and hospitals who utilize PAs for patient care. Supervision laws add cost and delay the hiring of and the utilization of a PA. This has led to PAs being disadvantaged when applying for jobs alongside nurse practitioners. Moving scope of practice to the practice level will allow for customized, flexible, team-based care that will give collaborating physicians more autonomy on how to utilize PAs within their interprofessional team. It keeps the decision on how best to utilize each team member's skills based on their training, experience, and local patient needs at the clinic or hospital level. Also, it supports innovation in care models that requires flexibility in provider roles. This change will allow the physician-PA team to develop their specific team-based model rather than a one-size-fits-all. When House Bill 1 was passed in 2012, there was a push for increased regulatory oversight on who is prescribing controlled substances. But currently, PAs are not being monitored for the Schedule II prescriptions they recommend, but instead, physician prescribing numbers are being falsely inflated. Allowing PAs to take ownership for these Schedule II prescriptions will improve oversight. It will also improve patient access to timely, effective care and make care more efficient. For example, if a PA works with a surgeon and is discharging a patient from the hospital, that PA will either have to take the surgeon out of the OR to get a prescription signed, have another physician tangentially involved in the patient's care sign the prescription, or delay the patient's discharge until the surgeon is out of the operating room. We included the update to allow physician assistants to perform driver's license vision testing, as patients and PAs in the community have asked why PAs are unable to perform this testing for their patients. PAs are trained to perform thorough eye exams during our training and competent to provide these services. PAs can function as primary care providers, so if a PA is unable to perform this exam, it can lead to added expense for this patient. I'm going to skip the summary part so I can wrap up. I do feel it is important to reiterate what this legislation does not do. It does not create independent practice for PAs. It does not allow PAs to direct bill. It does not limit the ability of the collaborative physician to delineate practice parameters within the collaboration agreement, and it does not stop the collaborating physician from restricting controlled prescribing by the PA. In closing, a PA scope of practice should be based on their education, training, experience, competency, and includes the professional activities they are qualified and authorized to perform. Outdated laws arbitrarily limit what a PA scope already is. Our current legislation regarding supervisory practice and Schedule II controlled prescribing were written early in the profession's history, and they were thought to protect the public from, at the time, an untested profession. But data has shown PAs provide safe and appropriate care. These laws now decrease access to care, increases cost of health care, and create other unintended consequences. I want to once again thank Chair Meredith and Chair Mosier and the committee members for allowing me time to present today, and happy to answer any questions.
Thank you. We do have questions. Representative Bratcher?
Thank you, Chair. So just appreciate the presentation. Just real quickly, I was reading here, and I think you said that PAs would have 1 year of experience to prescribe medication. Is that right? Narcotics?
For controlled prescribing, that is currently in our legislation for controlled 3 through 5, yes, sir.
But when they do that, they're under a physician's license, right?
So when we write for 3 through 5, it is not. It's under our license, but does have to be signed off on by a physician.
Okay, so it's my understanding that nurse practitioners have to have a 3-year collaborative agreement before they can prescribe on their own. Is that correct? So you're wanting to lower it less than what they have for PAs?
So the 1 year is what's currently in statute, and we are not able to prescribe Schedule II at this time.
Okay, thank you.
Yes, sir.
Thank you. Any other questions? There being none, I thank you for your presentation. Look forward to the continued dialogue with you folks in the Kentucky Medical Association, and we'll see what the final legislation looks like when we come back in January. So
Thank you, Mr. Chairman.
thank you.
Thank you.
Appreciate your presentation. Next order is the potential legislation for 2026 regular session, an act relating to protect vulnerable people. Representative Tate. Representative Nemus, former legislator Adia Wushner. Just like old time, isn't it, Adia? Glad to have you here. If you would, each identify yourself for the record and feel free to proceed.
Kentucky State Representative Nancy Tate, representing District 27.
Ladies first.
Adia Wushner.
Is your mic on?
Adia Wushner, Executive Director for Kentucky Right to Life.
I guess she left the legislature. She forgot all the rules.
That's right.
Jason Nemus, State Representative, Jefferson, Oldham, Shelby County.
Thank you for all being here. Please proceed.
So, Mr. Chairman, thank you for allowing me to come down here. I stepped out of a meeting. I'm going to jump back up, but I wanted to come and make sure that my presence is registered and my support is registered for what we've done here. There are several provisions that Representative Tate and Wushner, former Representative Wushner, will go over. I've been involved in it, many of these provisions, and just wanted to be here to support, to lend my support to it. I've got to go back upstairs, but I did want to sit here and tell you how much I appreciate the opportunity to come and just say I support it.
Always good to see you, Representative Nemus, and you're welcome anytime.
Thank you, Mr. Chairman. If you were a judge, I would say Your Honor may be excused.
You're excused.
Thanks.
Thank you, Mr. Chairman, and members of the committee. I sincerely appreciate the opportunity to be here today. And so in the essence of time, I'm going to turn it over to Adia Wushner, Executive Director for Kentucky Right to Life.
Thank you, Chair. chairpersons, both of you, and members of the committee. We're here today to talk about protecting vulnerable Kentuckians, a proposed piece of legislation for the 2026 legislative session. So when we look at that, we're going to talk about a broad spectrum, but from the beginning of life to the end of life as we begin to, and I know we need to kind of go quickly, so this is going to be just a high kind of overview of this, but what we need to do and some gaps in the current laws of how we protect our Kentuckians. The framework really unifies these issues under one clear mission to ensure that Kentucky laws are applicable to circumstances of today's culture, the culture that we live in today, defending the dignity of all human beings and all life in Kentucky from exploitation, coercion, and commodification. So as we look at some of the issues that we've studied and have been brought forth, we continue to see where there are gaps. And most of those are not because we don't have laws within the state protecting Kentuckians, but happens that we need additional laws, additional protections, and that would be on the illegal abortion pill trafficking that comes into Kentucky from out of state, from the marketing of minors. Some of you that may live in a rural area of Kentucky may have seen an article that we wrote. A marketing company in the rural areas of Kentucky targeted 100 gas stations because that's where sometimes people gather, where they get their information, between Kentucky and West Virginia for marketing illegal pills, abortion pills, 24/7 available, and how that young people, especially teens, would obtain these in minors. So all of that we have documented, so it's not that we're just giving you kind of what we think. It's all documented from articles that have been out there and from their own advertising. They were very open in their advertising. It's called Mayday Health if you'd like to look that up. Abortion travel targeting minors, and so those are also documented. Commercial surrogacy and what we talk about, the commodification of women and children. You know, in Kentucky, and we'll talk about that in a minute, we do not allow for the purchasing of corneas, body parts, but what we have allowed, not altruistic, but we'll talk about that, not a family member to a family member, but where high dollars are paid for women to be paid to be carriers of children, and these children are then sold by the highest bidder, sometimes up to $100,000. And the countries and other states that do not allow this. Also the pressure for what we call medically assisted aid in dying. And we've seen that growth. It is now legal in 12 states, well, now 13, because Illinois just passed in the dark of night at around 2:48 a.m. They kind of gutted one bill, moved it in, and passed legislation there that would allow assisted suicide and euthanasia in that state. But what we're seeing happening, and I'm just going to briefly touch on this, in Canada and other bordering states, it's not just for those that are very ill at the end of their life, terminal illness. It is for mental illness, and also we're seeing it for minor children. In Canada, by their own reporting, one in every 20 deaths is assisted in the country of Canada. And then again, just breakdowns with the organ procurement. Most of you can recall the news articles that were out there earlier this year. It's been part of a 3-year study where, you know, this is where Kentucky doesn't want to be in the news, where we had over, I think it was cited that 20 cases that the organs were received or attempted to receive from patients that had not actually been declared dead or were declared dead prematurely. And how can we put some safeguards there so that it doesn't happen to citizens in Kentucky? So death by mail, death tourism, this is the abortion pill trafficking, assisted suicide. So if we look at this, and again, would be imposing for those that are, we can't do a lot. It's not happening within our state only from those outside of the state providers or what we call repackagers. And that would be, let's say that you want to get into selling socks and you decide to order a case of socks and then you want to repackage them and sell them, 3 pairs for $1 out of your home and out of your basement. That is also happening here with abortion pills by people who are not even medical providers, by individuals who are there to profit off the market, buy a 3-pack. And unfortunately, sometimes these come in a kit called kill pills. So for those that want to profit illegally against Kentucky laws, there would be criminal penalties along with civil remedies, increased penalties, civil penalties, criminal penalties for the outside of the state marketers coming into the state, breaking our laws, as you would think of a drug trafficker, moving these medications up on the schedule to a Schedule 4 would kind of enact that. Also, to increase the penalties, criminal penalties for trafficking to a minor child or taking a child out of state, a minor child out of state without their parents' permission. Disclosure for and digital disclosures, the marketing that's going on to minors right now. So again, criminal penalties, and when there is harm, allowing for a wrongful death for civil remedies for parents of children, or perhaps for that young woman who was treated in the emergency room to receive those medications out of state. And sometimes we want to make sure when they do present in the emergency room that they feel that they could be honest with that healthcare provider versus coming in and saying, I've got bleeding for an unknown reason. So we want to make sure that women in Kentucky feel safe in seeking medical care appropriately, but know that they do have the right for civil remedies if necessary, but that it's criminally wrong for someone to sell them. So there's two pieces to that. When we look at the medically assisted aid in dying, Kentucky statutes have long been in place that says assisted suicide and euthanasia are illegal in the Commonwealth of Kentucky. So under this protecting vulnerable citizens, similar to the medications that would allow for the termination of a child coming in, it would then have the same protections, increased criminal remedy, but also that civil liability remedy for those who might be harmed. And I'll just give you a quick instance. There was a man whose family here in the state, he lingered 19 hours. They were not aware of what was going on, just said, please don't take me to the hospital, let me die in peace. He had been ill for some time. They later found his kit and his package where he had received it from another person who was able to obtain his assisted euthanasia medications from Canada. So we know that they are being marketed quietly and coming into the state. And again, criminal penalties along with civil remedies because they are breaking Kentucky laws. So just a little bit more. Again, it's legal right now in 12 states, including the District of D.C., and we've already discussed Canada. Last year, you may not have noticed, but there was a bill filed called Death with Dignity, and that was a bill that would have allowed an expansion of euthanasia here in the Commonwealth of Kentucky. So those bills have already been attempted to be filed here in the states. I wanted to increase your awareness of that and why we need to look at that and address it in protecting vulnerable citizens. Kentucky's organ donation, as I said, made headlines and there were actually congressional hearings on this issue. We know that every day 15 individuals in the United States die waiting for an organ. So this is not against or an attempt to go against organ donation. It is donating the gift of life. What we want to make sure is the proper protocols are in place, and there have been failures in the system. So two suggestions would be that possibly there's been discussion of a joint Senate and House resolution asking Congress and the FDA and HHS to please work swiftly in perfecting the guidelines. But what has been proposed for states like Kentucky that have had these issues, that there be what's called a pause in procedure, which would allow for a pause in procedure when it is identified that there's still cardiac activity, possible cardiac activity, and that would include it's called Pause in Procedure Uniform Act, and so in standards. So that would be to safeguard that no organ is in the recovery process from someone where life still may be present, which is what happened with 24 Kentuckians in the past. That would be the immediate next of kin or that individual who was signed for those organs to be retrieved. Also, the attending physician and medical team, because it was reported on two cases that were reported in these cases that were brought before Congress that it was a medical team, hospital personnel that might be involved in the patient's care, or the organ procurement organization staff. Again, and that's what to have those protections like whistleblower protections so that wouldn't implicate their jobs. But if they see something that is outside the norm, so what it would require in organ procurement is we know that time is a very critical window. So you have just a short time. So that would immediately require them to make immediate further testing for a declaration of death before they move forward. Doesn't mean that they're not going to retrieve these organs, but they're going to take a second look, which would have protected the lives of several Kentuckians with our CODA. Now, moving on, and I'll call this kind of justice for Kentucky women. Again, focusing on the safety of women, as we talked about with the abortion pills coming in and their treatment. But another issue, we've been writing a lot. You may not have heard a lot about it, and I've just mentioned it, and that's a focus on commercial surrogacy. What does that mean? We are not talking about carrying a child for your sister or helping someone very close to you. We are talking about the large commercialization where carriers are hired for a price. There are ads in Texas that say, be a surrogate for $60,000, for $100,000. They're contracted carriers for children. And then the purchaser purchases the child. Under these contracts, the carrier is required to terminate the pregnancy if the purchasers change their mind or if there's a fetal anomaly. You may have heard the story about the case in Florida or Texas where it was actually a former sex offender who was on the sex registry that became a surrogate parent, purchased a child. Also the case in California, these are on headlines that were just this summer, where there were 20 to some odd children or 30 children in a home. All of those were achieved through commercial surrogacy. And so when we look at this just opens a door for human trafficking. And when I talk about organs, many countries now, if you need an organ, you go and you purchase that organ outside of the country. Do you know where you go if you want to get a child? The United States. We are one of very few countries that do not have guidelines on commercial surrogacy. Many countries straight out ban it. So several states have already enacted. And so what we're asking that we don't want the womb to become a marker plate. Women should not be used as commercial vessels. Louisiana, Nebraska, Michigan, and New York have already put some guidelines. And so for this next legislative session, that the commercial surrogacy, again, not altruistic, be restricted here in the Commonwealth of Kentucky, that our doors are not open for selling children. One other area that we've looked at and looking at is the area of infertility, being very sensitive to the number of couples that are experiencing infertility and seeking a child and using assisted reproductive technology, or IVF, as you might commonly hear it called. What we don't know in Kentucky is what is the numbers? What are those numbers? The numbers that come forward in Kentucky are extrapolated by national reports through CDC and then SART, which is a reporting for assisted reproductive technology. But our numbers are just aggregated out of that, a percentage. So just as we have and this would only be statistical reporting, just as we have statistical reporting on every other thing that we do in the Commonwealth of Kentucky, this would include statistical reporting on just like the same report that is done at the CDC level, the same language just about, but it would be for Kentucky providers of assisted reproductive technology, so that as a state, we have an understanding of how many couples are using the procedure, not by name, but the age range, and maybe begin to understand a little bit why we're seeing such an increase in the level of infertility in couples too. But how does it impact not just a number that's coming to us by a national aggregate number? So that's, again, only statistical reporting on IVF practices in the Commonwealth of Kentucky. And then we'll be bringing back and support. It's been filed several times, and that's the Education on Human Development, and that would be Baby Olivia. I guess we'll call it Act 3. I don't know how many times, Representative Tate, you filed this bill. So that's in the wrap sort of legislative priorities. One would be that piece where I named up quite a few areas of protecting vulnerable Kentuckians. The other one would be restricting commercial surrogacy, and then statistical reporting in IVF, and then again coming back to support Baby Olivia in education on fetal development. Thank you.
Thank you. And before we take questions, it kind of gives me an opportunity to talk a little bit about the next legislative session. And this isn't speaking to your all's proposed legislation, just the process is that we see too much legislation. And I don't think we spend adequate time vetting many bills that are presented to us. So to that end, my intent this next legislative session with Health Services that the maximum number of bills that I will hear in a committee meeting will be 4. Because again, if we can't commit 20 minutes to each bill for discussion, it really doesn't warrant, I think, consideration, and it's going to become a law of the state. Now, if it's a controversial subject, the potential exists that it may be one bill that we'll hear during a committee meeting. But I just want to kind of set the stage going forward for folks that we need to be a little bit more diligent in these discussions. To that end, you covered a lot of territory here. Representative Tate, do you envision an omnibus sort of bill, or are you going to have several individual bills? But what's your thinking at this point?
Yeah, so at this point, I'm thinking about having an omnibus bill as well.
All right.
Yes, sir.
That's-
With baby Olivia being outside of that.
All right. I appreciate that.
Yes, sir.
Questions, Representative Wilner?
Thank you, Mr. Chairman. Thank you for your comment about limiting the number of bills. It's, this is important, serious work that we're doing, and we need to be able to vet things appropriately. So thank you for that.
Thank you.
Yes. Thank you for your presentation. It was hard to know from the agenda what this was going to be. The materials weren't loaded until this morning, and so it was hard to prepare. But as I saw the title, An Act to Protect Vulnerable People, I was reflecting on how vulnerable pregnant women are. And pregnant women are incredibly vulnerable in this entire country. Pregnant women in the United States are more at risk of dying in pregnancy than in any of our peer nations. And Kentucky is one of the most dangerous states in which to be pregnant. States that have enacted abortion bans have made pregnancy more dangerous for vulnerable pregnant women. So I think probably we share a common goal. We would like to see fewer unplanned, unwanted pregnancies. We would like to see fewer abortions. We would like to see fewer women having to make that very difficult decision, fewer medical providers being in that position of having to make life and death decisions under very tricky legal landscape right now. This is our last meeting of this committee, and I was thinking back to our very first meeting, which Representative Moser chaired, Chair Moser chaired, about the importance of data. Mm-hmm. And what the data shows unequivocally is that if we want to reduce abortions in this state, if we want to protect women from the vulnerabilities of being pregnant, if we want to protect providers from the legal scary landscape, there are 4 absolutely research-based ways we can do that. One is access to contraception. One is comprehensive, medically accurate, age-appropriate sex education, which I would argue very clearly that baby Olivia is nothing to do with medical accuracy. It's a cute video, but it is very far from accurate medically. Number 3 is to support parents and families. Providing insurance coverage, for example, for family planning has been enormously helpful in reducing unwanted pregnancies, unplanned pregnancies. And number 4, programs that curb domestic violence and sexual abuse. So I can imagine that we have some shared goals. Now, we've often been at odds with each other over this topic, I hope in a respectful way, but I think we really do share some goals. And I would really encourage you, plead with you as you craft this omnibus legislation to really look at research-supported solutions and not just maybe popular political talking points.
Thank you. Representative Camille.
Thank you, Mr. Chair. Thank you all for the presentation. It was interesting to say the least. I do want to point out one clarification. I was the sponsor of the Death with Dignity bill, and unfortunately, your representation of it was a mischaracterization at best, and I am happy with any member on this committee. Anybody who wants to have a serious conversation about what this bill does section by section. It does not conflate end-of-life care with death kits. It's something that deserves a real look so that people can understand what it does. So that being said, listening to the goal, we all want to protect the health care of Kentuckians. We all want to make sure that we have access to health care in Kentucky. And I was thinking about this on my drive from our retreat to Frankfurt to be here for this meeting. I was trying to think of what can we do that would really help protect vulnerable Kentuckians. One of the top things we could do is to make sure that Kentuckians have access to health insurance and access to their SNAP benefits so that they can receive the medical care that they deserve, so that they can feed their families and eat. Historically, people have traveled across state lines into other countries to receive medical care, right? We see it, people who go to MD Anderson, people who go to the Mayo Clinic, people who go to Cleveland Clinic, people who go to other countries for whatever care is, or if they want plastic surgery, whatever it is. But just hearing the overview of what your plans are for this bill really concern me, and I would really love to be able to have the chance to sit down and talk with you, Rep. Tate, just to have a conversation about creating a police state, creating something where you're stigmatizing and targeting very vulnerable individuals. There's constitutional issues with what you're doing because there are parental consent bills. My request is, could we please sit down and have a conversation? Because I think this will create way more problems and unfortunately cause unintended consequences, including the death of women and young girls in Kentucky. So thank you.
Thank you. Senator Berg.
Thank you, Mr. Chairman. I'm going to be very, very brief because it was an extremely long presentation, and we just don't have time to discuss all of the nuances of what you're talking about. I'm going to just 4 points very quickly. You mentioned cardiac activity versus brain death. I'm used to using brain death, not cardiac activity, as a measure of whether or not somebody is dead and eligible for organ transplant. Are we going to take that option away? You don't have to answer. These are questions for later
I
on.
just want to say that there are 3 elements that's changed since you and I were practice or more. They now do cardiac, brain, and circulatory. We're not addressing what's the determinant of death. We're just saying sometimes with patients there needs to be a second look. Thank you. I just wonder.
You specifically mentioned cardiac activity. Cardiac activity is not necessarily an indication of anything viable, and we know that whether you're being born or you're dying. Okay. 2, if you want to get an idea of IVF and the utilization of IVF in the state, and I will tell you, I have had practitioners call me in tears asking me, do I need to give up my practice and move my family and leave this state? Multiple. If we had an all-payer database, you would have your answer immediately, and it would answer multiple other questions as well. Baby Olivia, it's a beautiful video. I have watched it multiple times. It is technically completely inaccurate. It is up to sometimes 8 weeks off, and its description of what's happening with the fetus. To make that a rule in this state, to take something that is so inaccurate and require it, you can get, okay. And then the last thing I'm going to say is that a good death is a gift that you cannot ever replace. It is amazing. And I have been there. I have done that so many times. And I can show you what a good death looks like. I can show you what a horrible, miserable death looks like. They don't teach that very well in medical school. They do not teach us how to make sure that somebody dies comfortably and in peace and with dignity.
Thank you. Appreciate that.
Thank you. That's it.
Last question on this section or comment, Representative Burke.
Thank you, Chair. And I'll be brief as well. The gamut that is run by this potential omnibus legislation is really troubling because there are things we might find agreement on. And I don't think that every member who is forced to vote yes or no is going to have alignment on every one of these issues. So I would welcome a conversation where we could find things that could move forward as bipartisan legislation, as opposed to an omnibus bill that I promise you I would fight. The reason I'd have to fight that is because Kentucky women pregnant women are 37% more likely to be shot than non-pregnant women. So if we want to talk about vulnerable people, then pregnant women are vulnerable people. They are vulnerable to gun violence. That happens at a much higher rate than the things that this presentation has considered. So if we want to go down this path, I would be happy to help with creating a portion that responds to gun violence so that women who are pregnant don't have to worry about being murdered by their child's father or someone who isn't happy with that pregnancy. I'm also curious why the proposal doesn't include anything about the fees that are required of someone who wants to donate an embryo. So you might be familiar with embryo adoption. So embryo adoption is something that lots of families consider when they have embryos remaining after IVF. But here in Kentucky, the most common organization requires you to pay them to take your embryo. So that's a Christian organization. And if it's about preserving life, why do you have to pay them? And then they turn around and find an adoptive family and there's money on both ends, it seems. That doesn't seem right to me. That's not about preserving life. And it seems actually that that's more commercial in purchasing a child than what you've talked about, commercial surrogacy, which is actually a contract for the labor of carrying a baby. Going through IVF, and that's what a surrogate would be doing, receiving someone else's embryo and growing that baby. That's a lot of doctor's appointments. It's a lot of time off work. You can't try and do all the things and expect someone to do that for free just because they're kind. Because if that was the case, there would not be a market for paid surrogates. There's a market for paid surrogates because birth is hard. If it was easy, then I would sign up and do it again, but it's not easy. I feel insanely and beautifully blessed to have the two children I have. And I would go through all the heartache and grief that it took me to get there again. But I couldn't, in right conscience, say to someone else, I'll do that for you. Because that would put me at risk. That would put my children at risk. I don't want them to grow up without a mom. So when we think about commercial surrogacy, we're not purchasing children. That's a gross mischaracterization. We are purchasing 9 months or more of a woman's life where she is putting herself second and putting that baby first, making the food choices, making the nutrition choices, that do I drink the diet soda or not drink the diet soda? Do I give up coffee for the next 9 months? If I get gestational diabetes, which has nothing to do with me at all, but everything to do with the placenta, am I going to take all the medication that I need to take to keep that baby healthy? So it's a huge thing. It's a huge thing that we need to honor. And when someone is willing to put that much of themselves aside to try and help another family, they ought to be compensated for all the sacrifices they're making. So I really bristle at the notion that we're buying babies, because what we're doing is honoring the work of women. That's really sacrificial work, and it's worthy of pay. So I take great exception to that. Lastly, the last time we were discussing these kinds of topics, we talked about exceptions for fatal fetal anomalies. And there was a promise made to me that we would work on that. No one has approached me. I have made overtures to try and get that moving. But when we talk about the most incendiary topic of death tourism, I find great offense with that turn of phrase, because it is a really distasteful way to talk about women who leave the state to end pregnancies, wanted pregnancies at times. When we talk about death tourism, but we fail to work on exceptions for fatal fetal anomalies, we set people up. We push them into a trap where we then call them death tourists. What an ugly thing to say about someone who wants to be a mother. And when you cast such broad strokes with such a far-reaching bill, it's clear to me that it's not about doing the right thing, because doing the right thing is taking a slow and methodical approach, looking at things in great detail, filing each one of these as a single bill, and workshopping them all so that the things you want and the rest of us want, do happen. We don't want children to be trafficked. We don't want people to die from lack of access to care. We don't want many of the things that you've talked about. But the fact that this got placed on the agenda this morning makes me, and then materials with typos and pages drawn from the internet, it feels very rushed, and I'm quite perplexed about why it wasn't more thoughtful, because these are life and death issues. So that's my feedback, and I hope that we can find a way to work together on it. Thank you.
Representative Burke, I appreciate your comments and feedback, and it just illustrates exactly why we present bills during the interim to get it out there. I don't like to see anybody be surprised when we go into session. I appreciate your willingness to have continuing conversations on this. I would encourage all of our members to do the very same thing, that when we come back in session in January, and we don't hear all of our bills in January, it goes into February and March, is to have that dialogue and have the discussion, and hopefully we can respect everybody's opinion on this matter and bring some type of action to fruition. I appreciate that. I said you were going to be the last comment, but I'll make an exception, but we need to move on very quickly. Senator Tishner, the last comment falls to you.
Thank you, Chair. I just want to say thank you. I know you've gotten a barrage of negative comments about this legislation and the efforts that you're taking to preserve and protect human dignity and life in its most vulnerable form. And I think the majority of the people that sit on this committee do support these measures. And I look forward to the discussions as we move forward into the session. So thank you for your work.
Representative Tate,
Thank you
appreciate
very
being
much.
here today.
Thank
Look
you.
forward to talking to you when we get back in session.
Sounds
Idea,
wonderful.
you're always welcome here, and appreciate the work that you do. Thank you.
Thank you.
Next topic is Rural Health Cancer Innovation Coalition. Dr. Rick Lozano and Rob Gebert coming forward. Before you gentlemen start, we had our Medicaid Oversight Advisory Board meeting this morning and talked a little bit about the Rural Health Transition Grant. This policy is going to change rural health care. And I made the comment, and this is just a personal opinion, that no fault of Dr. Stack and his folks at the Cabinet for Health and Family Services, but what I see is truly not going to transition rural health care. And that's why I'm very excited to give you gentlemen an opportunity to talk about something that could be transformational for rural health care. So with that, if you would, introduce yourself for the record.
Rob Gabbert, Vice President of Business Development and External Affairs for PNC Labs.
Dr. Richard Lozano, pathologist and president of PNC Labs.
Thank you for being here. Please proceed with your presentation.
Chair Meredith, Co-Chair Moser, and members of the committee, really appreciate y'all having us here today about an exciting new initiative we call the Rural Cancer Innovation Coalition. And our mission is to bring the future of precision cancer care to all Kentuckians. So the coalition has a few main goals. We want to keep cancer patients in rural hospitals, get them the treatment they need at home. We want to provide precision cancer testing and access to clinical trials right there in your hometown. We want to reduce cancer care costs for the state and extend lifespans. And we do this by doing rapid precision molecular testing so that by the first time you see your oncologist, that oncologist knows everything about your cancer that's specific to you, what treatment will be most effective, what clinical trials are available, all without leaving your rural hospital. And there's a lot of times, you'll hear about a patient or a family member that they are diagnosed with cancer and they start treatment, and then 6 months later, they realize that it didn't take. And so we want to prevent that. And so this testing allows us to know all the answers up front and just completely eliminate that.
All right, well, I'm a pathologist, and in case y'all don't know what we do, because we're behind the scenes, but when you go to the hospital, when you go to your doctor and they do a biopsy, they send it to us and we process the tissue look at it under a microscope and give your doctor a diagnosis so that they can then discuss it with you. We've been around since the mid-'60s. We practice from this humble building in Lexington, and we serve about half the state. It's about 42 hospitals from Pikeville to Paducah. We send couriers out to all the hospitals every day. It's physician-owned, and we're really in a position to serve the whole state. We know what our hospitals want, and we provide the same level of pathology care and service to the small hospitals like Rockcastle or the big hospitals like Central Baptist. It's the same level of care. We do this by acting as the pathology department for that hospital. In most cases, they can't afford to have a pathology department, so they turn to us. We are the acting pathologist within that hospital, an active member of the medical staff. We also serve as the medical director of the laboratory. So the laboratories can't operate without our advice and guidance. We make sure they're using the right policies, following the regulations appropriately. And if any of you have been to a doctor's office or hospital, you know nothing happens until you get your blood drawn. That's usually one of the first steps. We're on call 24 hours a day, and we're available in that mode to discuss any clinical blood tests or cancer tests. And we do this, this is part of our continuous collaboration with our oncologists and hospital teams. We serve on tumor boards, and we serve on cancer committees, and really our ethos is 24-hour turnaround time. For most of our biopsies, we try and get an answer within 24 hours.
Like most industries, technology and AI are impacting them significantly, and pathology is no different. We are leaning into that full steam, and one of the handful of labs in the whole country that are implemented a fully digital pathology workflow. So what that means is that instead of looking at a slide under a microscope, we digitize these slides and look at them on 4K monitors with NVIDIA GPUs. And what that does is it gives us a higher fidelity. We know a lot more about the cancer, but also it enables us to use AI algorithms to better detect stuff faster and get it and make our docs more confident in the diagnosis. We're the second lab in the United States to have an FDA-cleared AI for women's health screening. We are now a member of an AI consortium with Pittsburgh Medical Center, Cleveland Clinic, and San Francisco Hospital, and we're developing our own AI tools together. So that will let us in Kentucky have access to the latest and greatest AI algorithms. We are experts in oral pathology, and we also, like other healthcare industries, there's a workforce shortage, and we have the state's only cytotech and histotech training programs in-house. And we'd like for everyone to stay, but sometimes they go elsewhere, and we're perfectly fine with that.
So what you're seeing is a cell spot on the right, and this is currently what a pathologist has to look at for a Pap test. And what we brought in-house a year ago is an FDA-approved women's health cancer screening AI module for Pap smears, for Pap tests. And so the cell spot on the right has anywhere from 100 to 200,000 cells. It's literally like finding a needle in the haystack. What the AI module does is find the abnormal cells, present them to us in this gallery on the left in a manner that we can easily look at and make a diagnosis.
So just to give you a little bit of info on who are we serving. So when we serve a hospital, we agree just to serve. We just pick up the specimens they send us. We get our cars, we pick them up. We don't choose insurances, and so the payer split is about 50% CMS with 25% Medicaid, 25% Medicare, and then the rest is commercial. And a lot of the Medicaid work we do, we're reimbursed below the cost of our cases. So let's get a little bit more into deep detail about molecular testing or next-gen sequencing.
So what this test does, next-gen sequencing, it opens up the DNA so that it can be read. So with this test, we can look at the genes that the patient has, that the tumor has, and look at the mutations. This is typically done almost as an afterthought. What happens most of the time today is a cancer patient goes through an algorithm of treatment, what typically works, and after 6 months when that fails, then they get NGS testing to see why the treatment failed. And in some instances, that original treatment precludes the patient from getting the right treatment if they only would have known. And so why is this? Because it costs too much and it takes too long to get the results. And so really what we want to do is we want to optimize the outcomes by moving this test forward in treatment and delivering it within a quick turnaround time and at a low cost.
So we have a few problems and opportunities that we've noticed. So, we want to make sure that cancer patients in rural hospitals are confident that the treatment they're getting is the best. And, sometimes they leave the hospital for whatever reasons, but that delays care, it adds higher costs, and it loses revenue for community hospitals. So we want to provide the oncologists with all this information up front so that they can be confident and the patient's confident to stay there right in their local hospital. Currently, these tests cost up to $5,000 and are sent out of state. We want to reduce the test down to about $500. And currently, our customers are sending out about 700 of these a year. So they could do 10x the testing for the same price, or they could save money. It would be up to them how they determined to work with us. But in the typical fashion, it takes up to 5 weeks, and we're getting a call from the oncologist. We have to package up this tissue, send it out of state. Comes back about 5 weeks later. Sometimes it's faxed in a different report. We want to deliver it in less than a week in the same pathology report that they're already familiar at looking at. And we just want to really apply the same principles that we're doing with the pathology lab, with that next day turnaround, but to the NGS sphere. And so really we want to get this plan to work. It's got to work at scale. So the machinery, it costs the same to run one test or 60 tests. So there's a volume-based business. So if you can run all 60, then it's a lot better. The cost per test goes down. It's a unit economics thing. So we want to drive those costs down, and we do that by purchasing equipment and reagents. We want to establish a tumor board so we can look at complex cases and connect patients with clinical trials. And we also want to leverage new AI tools to kind of accelerate that pathology diagnosis. So once we make a diagnosis, we already have that tissue. We can go ahead and put it on the sequencer. So that's really our advantage. And so what we're here today to ask for is a budget request for $5 million over 2 years. The first year we'd ask for $2.5 million. That would give us the capacity to serve half the state. And if we hit the metrics that we anticipate, we have clear metrics and goals, then we would come back in year 2 and go ahead and buy higher throughput, higher automated equipment so we could have the capacity to serve the whole state.
So really what we're looking to do is serve the whole state. And we know we have the capacity to do this on a pathology level, but on a molecular level, we don't at this time. We know where the puck is heading. We know where medicine is going. It's going to precision medicine and precision treatment plans. We just want to get there first, not last. And so by this cooperative, we can work together to bring this test into the forefront and do it first instead of when there's a cancer treatment failure, and give our patients, we already have the highest cancer rate, the highest cancer mortality. Nobody needs this more than Kentuckians. And no one else is going to do this for Kentuckians other than a lab that is focused on serving our docs and our patients. Any questions?
We have one person who signed up to speak on this matter, but let's go ahead and take questions first, and then I'll bring that person up. Co-Chair Moser.
Yes, thank you, Mr. Chairman. Thank you for your presentation. This is really interesting. I think it's very needed, and I don't disagree that this is the way medicine is going. We passed a bill a couple of years ago to require that insurance providers cover biomarker testing and pharmacogenetic PGX testing. How is this different? How's this molecular testing, the NGS testing, different from the biomarker testing?
It's the same type of testing, but I mean, it is biomarker testing. But right now, it typically follows a 14-day rule where the patient has to be out of the hospital for 14 days before it can even be ordered. And so that sets a couple weeks there as a 2 to 3 week buffer just before it can even be ordered, let alone tested and the results come back. Most insurance companies do not cover this, even for a cancer diagnosis.
And so they would cover this testing?
They would not cover it. No, what we're doing is by this partnership of this legislation paying for the equipment, we know we can drive the cost down to a level of $500 that the hospitals would pay.
May I have a follow-up, please?
Yes, please.
Okay, so you talked about the volume of testing. Eventually you want this to cover the whole state to make this cost effective. And I understand that sounds like it's going to take a long time. I'm not exactly sure how one small lab is going to really do this. So I mean maybe you've got it worked out. Is your lab a for-profit organization?
It is a for-profit.
Okay.
We do have a nonprofit arm that would operate much like a hospital foundation, or would be open to running it through anyone. Really, the more guardrails are better. We don't much mind as long as we can get these costs down and get this care to people.
Okay.
And we know we can cover half the state with the space and with the equipment we're asking for. And we already know if we get the right equipment up front, we could cover the whole state. So our oncologists have helped us, although they want to test every cancer, they've kind of limited it to specific cancers that need this testing more than others. And so they're already putting some guardrails on it, but that will, in a sense, limit it to a number that we can cover the whole state.
Yeah. And we also have 150 employees and 19 pathologists and run 24/6 at 3 shifts. So it's a little bit different, but we all like to call ourselves Amazon Prime of pathology. But
okay, just a quick comment. I think it's a novel idea. I think it's a good idea. I mean, normally these procurements go through the cabinet, and so I don't know how the budget request for a private organization would really work without looking at who else does this, and maybe there isn't anyone else. But have you had any conversations with the cabinet about this?
we have not. We've talked to the Department of Medicaid about it, and they seem pretty encouraged that they can see the overall cost savings. So we are trying to get a meeting with Justin Derringer, who spoke the other day, about getting some CPT codes. They seem like they were interested in actually covering it.
Okay. All right. Thank you.
Thank you very much.
Senator Berg.
Thank you very much. And I'm a little confused. First of all, so you're sort of like a telehealth pathology firm. Like you can read for multiple hospitals, rural hospitals that don't have their own pathologist.
But not telehealth. I mean, we go to the hospitals.
So you're available for an FNA, you're
Yes.
available, and so you're actually physically on site doing the services.
Some services, yes. When they need us, we come there for those services.
Okay, and you get paid for that?
Yes.
Okay. My second question, knowing different tissue types and different tumors and different markers and what we can test for at this point and what we know exists and we don't have the test for it and all that stuff. Are you talking about one test for all tumor types, or are you talking about a specific test based on the origin of the tumor?
It's a panel of 58 genes. So right now, the test that goes out of state is a comprehensive panel of over 600 genes.
Right.
And that's partly why it costs $5,000. But this test is much more reasonable. It'll give us the answer we need 90% of the time. And so 90% of the time, we're going to get the answer from this panel. When it's all negative or we don't get the answer, say we don't find a mutation, we've got a molecular partner that is interested in that panel, interested in that patient. And they will do the comprehensive panel at no charge. So it
For
really
your
is,
negatives.
it's a partnership between, what's necessary, and then when that doesn't work, what then becomes necessary. So the comprehensive panel is not necessary for every cancer patient. So yes, this is a 58 gene panel for solid tumors, not for leukemia, lymphomas. Yeah. That's a different panel, a different proposition completely.
So you're talking about breast, colon, lung?
Yes.
Okay. And then my second question, what type of tissue do you need?
We need formalin fixed, paraffin embedded biopsy tissue. So something that is either
open excisional biopsy, or can you do an incisional biopsy? Can you do it 14 gauge core?
Yes, you can do. It can be done on a core biopsy. It can be done on an FNA.
You can do it on an FNA?
Yes.
How do you preserve your material to travel with an FNA?
We preserve it in formalin.
You're putting your FNAs in formalin?
Well, they go into alcohol first.
Okay.
It's
So you're
processed.
not-
It's processed in our lab, and then a cell block is created in formalin from
Right.
the residual tissue.
Okay. Interesting.
Mm-hmm.
All right, thank you.
That's and that's being done. That's being sent to out-of-state labs right now from FNAs.
Okay. And you're just saying it's not profitable enough for a lab to set itself up on its own in this state?
Not at $500 a test.
Yeah, and until you get at scale, then it works, and then it would be completely self-sustainable from there.
Mm-hmm.
Last question and/or comment from Senator Nemus. And Senator Nemus, before you pose your question, comment, I'd ask Richard Bartlett if you'd come on up to the table just to kind of expedite this a little bit. Dick, are you here? Yes, sir. Please, if you would, come on up. Senator Nemus, go ahead and ask your question or make your comment.
Yes, this seems very interesting and sounds like the end result would be great, but you're a business and you're going to make profits off of it. Sounds like you could go to the bank and show them this return on investment and not come to us, because then you would have your business model, save money, make money, and we wouldn't have to put forth the money that may or may not be a good return on investment for the state.
Yeah, we were prepared for that. And, when you take on debt, it adds more costs to this stuff. And so we're trying to eliminate those costs. We could get there for sure over time.
You want to eliminate it to put it onto the state, because if it was so good as it sounds, a bank would lend you the money on it.
Well, if we kept it at $5,000 a test, we wouldn't be here asking for the grant money. But at the cost we're offering our hospitals, there is no margin. There's no margin to buy the equipment necessary to perform it. But that is at a level that the hospitals can accept and can see value in if it's helping those patients stay in the hospital
And
for treatment.
like Representative Moser was talking about, Chairwoman Moser, maybe you should go to the cabinet that does this instead of direct funding from us. Thank you.
Thank you.
Mr. Bartlett, if you would, please introduce yourself for the record.
Senator Meredith, I think maybe I think maybe I have made a mistake. I meant to speak on behalf of the topic, the trauma system alignment topic over here, so I must have picked the wrong number on the schedule. So my apologies, sir.
Well, I've known you a lot of years. First time I've known you to make a mistake. That's
Yes, sir.
But we'll kiss you up. Any other questions for these gentlemen? If not, thank you for your presentation.
Thank you very
Appreciate you
much.
being here.
Thank you
this
very much.
afternoon. Thank you. But Dick, you did give us a perfect segue into our next agenda item, which is aligning Kentucky's level 4 trauma coordination.
I will let the ARH folks take the stage first,
Yes.
and I'll back them up.
Sounds
Support
good.
them.
You know, this is another one of those opportunities, I think, to really enhance rural health care. Just as kind of a segue into this, we passed legislation. Well, I don't think anybody was here back in 2008, but in 2008, legislation was passed to establish a statewide trauma network, which has never had funds for appropriation to make it work. So we've kind of got a patchwork type of system throughout the state. Obviously, we want to change that. Trauma is the #1 killer in Kentucky for the population 45 years and younger, principally in rural communities where it's more pronounced because of our roads. And so we're trying to address trauma care, and these folks have an issue related to the current regulations. So if you would, please identify yourself for the record and proceed.
Hi, my name's Jessica Ambergy. I'm a physician assistant. I'm a doctorate physician assistant, and I've been practicing emergency medicine in the ARH system since 2011.
And I'm here on behalf of.
Rocky, make sure your mic is on.
Okay.
Green light on.
Yeah, it's on.
In front.
Okay, sorry.
That's right.
I'm here on behalf of Ms. Harris, who was unable to be here today. My name's Rocky Massey. I'm the Chief of Staff for Appalachian Regional Healthcare.
I'm Dr. Cody Reynolds. I'm a board-certified emergency physician. Been practicing emergency medicine for 14 years.
Thank you all for being here. Feel free to proceed with your presentation.
Yes, sir. So Chairman Meredith and Moser, I thank you all for the time today to talk about an issue that's very important to Appalachian Regional Healthcare, really, but also for rural hospitals across our Commonwealth. I'm joined today, as you can see, by a couple of two experienced clinicians who will share their expertise on the challenges faced in rural healthcare and a current barrier that we face. First of all, a little bit about ARH and myself. I am a 44-year employee of Appalachian Regional Healthcare. I started out in the trenches as a clinician. I have ran 4 of our hospitals across eastern Kentucky, 5 of our hospitals across eastern Kentucky and southern West Virginia. And I'm proud to have served my entire career in the service of rural health care. So I'm proud to be here today on behalf of that line. Appalachian Regional Healthcare is a not-for-profit healthcare system. We operate 14 hospitals and more than 90 clinics across eastern Kentucky and southern West Virginia. We operate in some of the most medically underserved and geographically isolated parts of our region, places where access to timely emergency care really can determine the difference between life and death. Today we want to talk about a very important subject, and that's trauma care. A trauma-designated hospital by the American College of Surgeons establishes a verified standard of readiness for hospitals to treat injured patients. It's not a ranking system, it's a quality assurance framework that ensures that hospitals have the staff, the resources, and the processes that are needed to deliver coordinated trauma care. Each level within the system, and there are 4 levels, 1 through level 4, really defines the hospital's capabilities and its role in a regional trauma network. Specifically today, we want to talk about a level 4 trauma designation because level 4 plays a critical role in rural areas, by providing initial evaluation of the patient, stabilization of the patient, resuscitation if needed, and transfer on to a higher level of care if necessary. For many of our Appalachian communities, a level 4 facility is the local access point for emergency trauma care. These facilities truly are the safety net in the communities that they're serving. Most importantly, what a trauma designated facility does, it lifts the standard of care for the entire hospital, not just the emergency department. A trauma designated facility drives improvements in credentialing the staff, the competency of the staff training, the equipment readiness, your imaging capabilities, your lab turnaround times, and all of your performance improvement measures. For ARH to be able to expand level 4 trauma designations across our rural hospitals will directly strengthen our regional healthcare infrastructure and ensure that every Kentuckian, no matter how remote, has access to coordinated trauma care. As we said here today, this afternoon, I'm sad to say that only 7 of our 12 ARH hospitals in Kentucky do not have trauma designations. 7 do not, 5 do. And there's a reason for that. It's not because we don't want to be trauma certified. We want 100% of our facilities to have the appropriate trauma designation. And it's certainly not that we don't want to make the investment in there. We'll do it tomorrow. But I would say this. If I travel across the border over into West Virginia, where we operate 2 hospitals, our hospitals there, 2 out of 2 are trauma certified. If you compare the states as a whole, and Mr. Bartlett can attest to this, approximately 20% of Kentucky hospitals are trauma designated, and 92% are designated in West Virginia. And there's a reason for that. And that's why we're here today. And these 2 folks are going to explain to you the problem that we have with Kentucky State Regulation 902 KAR 28.030, which serves as a barrier for Kentucky to be able to develop this comprehensive trauma network that we hear so much about. We want to lead that charge. We've got a transformational solution here for you all today. Jessica.
So Kentucky's current level 4 trauma standards state that a physician has to be physically present for a facility to be trauma designated. In rural Kentucky, that's an unattainable number of physicians for us to have. It's also unusually restrictive for rural hospitals. The regulation has become a barrier because we have advanced nurse practitioners and physician assistants that are career in emergency medicine practicing at this level of care that obtain the same certifications as their physician counterparts. They go to the same courses, they follow the same metrics. So this first slide shows what the current level 4 trauma designation requires. And highlighted in yellow is the wording that would be preferable to be able to have the model of practice that we currently use, to change physician to providers, saying a facility shall have 24/7 provider coverage in the emergency department. We do currently have off-site physician backup, and they are available to respond via telehealth immediately or in person per the facility bylaws. And then also would like to change the part where a designated Emergency physicians shall be present. We want them to be available in person or via telehealth, which is the way we currently practice. And these barriers do not align with national standards, which is what Cody is going to hit on.
Thanks, Jessica. We appreciate your time so much today. So the national level 4 trauma standards are set for...
Excuse me, but could you pull the mic a little bit closer?
Yeah, absolutely. I apologize.
Okay, thank you.
Yeah. So ACS, which is the American College of Surgeons, who designates your trauma level. Currently, the ACS level 4 standards allow 24/7 emergency department coverage by a physician or by an advanced practice provider. Even the American College of Emergency Medicine, which is the largest of the governing boards in emergency medicine, also has a national policy that supports a physician-led team that includes APPs with real-time physician supervision, which includes, like we do, off-site telehealth supervision in the designated rural facility types like critical access hospitals and rural emergency hospitals. This flexibility is really essential for Kentucky's rural hospitals to be able to meet both access and quality goals. I've been practicing in Eastern Kentucky since I graduated from residency. It is a very, very difficult place to recruit physicians. It's an even more difficult place to recruit emergency board certified medical physicians. Having quality APPs in the roles along beside us bridges that gap for Kentuckians. And then even, like they alluded to earlier, the trauma standards that are utilized by the states around us, if you just go across the border into West Virginia or to Tennessee or Ohio, they allow APPs, our nurse practitioners and our physician assistants to independently manage these trauma cases obviously with physician-led framework behind it. It's this, there's been talk today of transformation. I think this is the start of a legitimate transformation in the care of Kentuckians, especially, again, touching on another topic that we talked about earlier, our most vulnerable population. We're very isolated. I grew up in Pike County in a very rural area, 35 minutes at least to get to Tug Valley, which is where I practice at now. Once you get, out of the holler, it's really difficult. So, we need to be able to make sure that there's standardization and that we're not lowering the bar, we're raising it, and we're willing to put the work in to make sure that Kentuckians are taken care of. And that's what we asked for today, is the changes in that wording.
Thank you. Dick, you want to come up and speak to this now? If you would, again, please identify yourself for the record.
Yeah, for the record, my name is Richard Bartlett. I work for the Kentucky Hospital Association, but in this role, I am the Kentucky State Trauma Program Director, which is a position that was created by the statute that you mentioned, Senator Meredith, back in 2008. And I've been in that position since the beginning. I helped to write the legislation. I helped to write the regulations that we originally had. And I want you to know that I hear what these folks are saying. And I worked with the ARH leadership team to actually create a regulation modification, which included the changes that they are talking about. We actually, Julie Brooke from Commissioner Stacks went back when he was a commissioner. She worked with me on this, and we actually got it into the process, along with another regulatory change, which was very minor. And we got to the point where we had a meeting to discuss this, and a representative from the American College of Emergency Physicians here in the state became very vocal that the regulations, the standards that he mentioned were only intended for frontier states, and you have to have a doctor. It's the gold standard. Doctors got to be there in the ED 24/7, et cetera, et cetera. And we also heard from a representative from the American College of Surgeons Committee on Trauma, which does not do our level 4 standards. We have regulations in place, the ones that he referenced, which set the standards for level 4. ACS does levels 1, 2, and 3, but they were working on a set of guidelines to help those states who were looking for advice for level 4s. And so some of our members from the American College of Surgeons Committee on Trauma suggested that we basically put the change on hold temporarily while ACS COT completed their review. They were circulating the draft nationally for comment, and we participated in that, submitted that, got people to feed their feedback into this thing. But in a recent meeting that we had just had, I asked the representative from the Kentucky chapter of the American College of Surgeons Committee on Trauma where we were on this. Because when I went to a national trauma managers meeting this past spring, I actually talked to the national representatives that were there from the ACEP group and from the American College of Surgeons group. And I said, guys, here's where we are. This is the issue. This is the problem that I'm dealing with right now. And I need for you folks as the national leaders in this area to sit down. They said they were going to meet in June. I said, I really need for you guys to sit down and come up with a compromise that will meet this standard, these requirements, these needs, and then let us know nationally where we are. As of our meeting about a week and a half ago, I was told that the two national groups have agreed to disagree. The American College of Emergency Physicians apparently has decided that they are going to pursue legislation on a national basis. They've already done it in 3 states, and they are intending to approach you folks in the General Assembly in the 26th session for a law that would require a physician in the ED 24/7, no matter what, or you take the sign off the door. I'm not sure that's realistic, because I agree with what these folks are saying. I agree with what the gentleman from the presentation in number 4 said. In fact, the gentleman who presented your presentation number 4 talked about the problem being mostly in eastern Kentucky. I disagree. I'm running into the same problems in rural western Kentucky. In fact, I had a trauma center in rural western Kentucky that Dr. Stack and I had to suspend because they had periods of time during the week where they had to use an APP or a PA with telehealth consultation, and unfortunately it doesn't meet the current standard as you see it. So I think that we need to figure out how to go forward. As a trauma advisory committee, advisors to the commissioner, we can advise the commissioner, but ultimately the decision has got to be Dr. Stack's and his commissioners to what they want to do. And I think that they'll obviously be looking very closely at these recommendations from ARH. My group has decided they wanted to wait to see what ACEP, the American College of Surgeons Committee on Trauma, was going to recommend before they took any formal action. So we're still in a pause mode, unfortunately. I can't make a formal recommendation to Dr. Langefeld at this particular point. But that's where we are, Senator, and as a former administrator for a rural level 4 trauma center, I think you probably have a better understanding of this than many of your colleagues. It's a critical problem. And I agree that it's very difficult from what I'm seeing as I go out and do trauma site verifications for level 4 facilities. I've been on 3 this week, and I've got several set up ready to go for the next couple of weeks here. It is extremely difficult for these facilities to find, retain physicians in these rural areas. Many places they're using staffing companies. They're hiring young physicians, some of them right out of school. They may have a medical degree, but it may be in family medicine. It may be in some other related area. It's not necessarily in emergency medicine. And as soon as these guys or gals get a shot at a regular position somewhere, they're off, which then leaves them a gap. They've got coverage problems. It's a serious and significant problem. And I don't have an easy answer for this. I will tell you that we just did a survey as a Kentucky Hospital Association of our hospitals, asking them what their staffing situation was like right now in their emergency departments. And I think it's noteworthy that of the 85, I believe, facilities that responded to the survey, about a quarter of them came back About 17 of the 85 came back up, and some of them were critical access hospitals like yours were, Senator, rural emergency hospitals, which is a new category of facility where they basically have dropped their inpatient and they will do outpatient emergency facilities, emergency services kind of things. But they've come back, and many of them have said that this is a significant problem. And if there is a law that is passed that requires them to have a doctor in that ED 24/7, some of them have said that they may have to basically shut down their ED, or they would have significant problems in meeting that requirement 24 hours a day, 7 days a week. And that would be devastating for rural Kentucky. And I have great concern about that. So any questions you've got, Senator, I'll try to do my best to answer them
I
based
think
on
you've
what I
done an
know.
excellent job. Certainly, we're talking about just level 4.
Yes, sir. This is a problem primarily in level 4s. Level 1, 2s, and 3s under the American College of Surgeons Committee on Trauma Verification process are required to have physicians. Many of them have surgeons, so forth. It's a problem in the level 4s, how to staff the level 4s, particularly in rural areas. That's where we're running into problems.
Then the question becomes, again, noting that 40% of our population lives in rural Kentucky, only 17% of our primary care physicians are there, that is it better to have a level 4 that's directed by a PA or a nurse practitioner with ER experience, or not have a trauma center at all? And I think the answer is pretty obvious.
I have heard, and I'm not disparaging any of the physicians that are with us here in the room, but I've heard from several folks that, you know, a well-practiced, well-experienced, trained APP, advanced practice practitioner, and I will compliment the ARH folks. They have got an outstanding process for vetting APPs. It is probably a model, and I've distributed it to our other hospitals to look at as a model, because they go through and they credential these people, they monitor them, they will sign off on them. It's a very complicated, but it's a very thorough process. It's not just any physician assistant or nurse practitioner that's doing this. They make sure these are the best and they're well qualified folks.
Well, you made a point earlier about just because you receive the designation of a trauma center doesn't mean you get to keep that for life. You still have to meet certain standards. There's checks and balances in place.
And I go out every 3 years with a physician and a nurse who have trauma experience, and we go out and verify those facilities. I'm getting ready to add probably 5. I'm sorry, I'm getting ready to do 7 in South Central Kentucky, and I've probably got 2 of them in Eastern Kentucky that are getting ready to come on board. I'm going to add 10 more probably over the next 6 to 8 months. Our system is growing, and we're going to try to make sure we provide a quality product.
Well, I think that's what we're all interested in, but I'll go back to my earlier premise. Is it better to have a level 4 trauma center that's headed by a mid-level practitioner than not have one at all? And I think the answer is quite obvious. So if other states have done that, is that precedence here? I think it's something we should give serious consideration to, and we certainly will.
Yes, sir.
I'll be the one to file that legislation this next session for consideration. So,
Thank you, sir.
Thank you all for being here today. Appreciate you bringing this matter to our attention.
Thank you, sir.
Thank you. Our last presentation for today, Representative Duvall, we will be out before 7 o'clock. So, overdose prevention strategies, Van Ingram. Been patiently waiting. We appreciate that, and always good to have you before our committee. Again, you are last but certainly not least. If you would, please identify yourself for the record.
My name is Van Ingram. I'm Executive Director of the Kentucky Office of Drug Control Policy, and this month marks my 21st year with that agency.
Thank you, sir.
Hello, Sarah Johnson, Director for the Division of Substance Use Disorder within the Department for Behavioral Health, Developmental, and Intellectual Disabilities.
Glad to have you both here today. This is a very important topic, so please proceed with your presentation.
Well, we appreciate the opportunity to be here, and we don't want to be remiss not to thank the General Assembly for the funding that we have that allows us to do the things that we're going to talk about. Very grateful for the funding that we've had. So we know that we've reduced overdoses the last 3 years. 5% in 2022, 10% in 2023, and 30.2% last year. That still means that 1,400 Kentuckians died of a drug overdose, a preventable death. We've got to bring these numbers down, and we're working every day to try to do that. I'll talk about a few programs and then the key program, and then turn it over to Sarah. So one of the things that we do with the fund you provide is we operate a statewide call center. We pay Operation Unite to run that. It's 8338-KY-HELP. They take in about 3,000 calls a year. They take out about 9,000 calls a year because they follow up with every single person that calls 2 and 3 times. We think it's critical that when people wake up and say, I can't live like this anymore, there's a place they can call that will help them find treatment that day. And we've been pretty successful in the last several years of being able to do treatment on demand. That's crucial. Certainly our partners at University of Kentucky, Kentucky Injury Prevention Research Center, Find Help Now, ky.org. You go on that, do the same thing as our call center can do, and our call center uses that link every day. 2021, Representative Bowling sponsored a bill to create recovery-ready communities. And people told me, now, Van, what's the incentive you're going to give people to become a recovery-ready community? And I said, well, I don't think we are going to have any incentives. Well, people said, well, they won't do it. We have already got 31 counties representing 1.8 million Kentuckians who have been certified as a recovery-ready community. That means they've looked at what's available in their county, they've looked at what's not available in their county, and they've made the effort to help people in recovery stay in recovery. And that is so important. Another program we fund is SITE, the Strategic Initiative for Transformational Employment. We know that when people are in recovery, a good job can be the linchpin to keep them in recovery. As I travel this state, transportation and housing are constantly brought up as obstacles. A good job can potentially take care of both of those things. So we partner with EKSEP, Eastern Kentucky Concentrated Employment Program, and they've got folks located at our career centers around the state that are focused on getting people in recovery and jobs. I've partnered with the Chamber for 7 years to do fair chance training for employers, and we've trained thousands of employers around this state on the need to be a fair chance employer and what policies and procedures they can have in place. Then about 2.5 years ago, my office, the office Sarah represents, our Kentucky Department of Public Health and Louisville Public Health got together and started to develop a Narcan saturation plan. That just handing out Narcan, whether it be at the State Fair or a Walmart parking lot, was not strategic enough. We needed to get Narcan in the hands of those most likely to witness an event that would be useful in. For example, I've carried it since 2015. I go out one night a week to eat, and I'm home in time for Jeopardy, so I'm probably not going to run into anybody. So we've worked with criminal justice, we've worked with hospital systems, we worked with the Attorney General. The Attorney General had some Narcan coming in from a settlement, and we started an EMS leave behind program, where when our EMS folks respond, if they think it's prudent to leave Narcan behind, they have the opportunity to do that. Just that program alone did out 10,000 dosage units so far in 2025. So we really think the Narcan saturation plan is key to our reduction and our continued reduction in overdoses. And I'll stop there and turn it over to Sarah.
Thank you, and thank you for allowing me to be here today to talk a little bit more about the naloxone saturation plan. So as Van mentioned, our key objective is to achieve saturation, meaning naloxone is available wherever an overdose occurs. In order to achieve saturation, we have to reach 80% of witnessed overdoses and expand the overdose education and naloxone distribution through a coordinated statewide infrastructure. We're prioritizing high-need counties based on readiness and overdose data. Between October of 2024 and September of 2025, we've distributed over 148,000 naloxone kits, along with more than 616,000 drug testing strips. Strategically, we're focused on strengthening cross-agency coordination, prioritizing people most likely to witness an overdose, and improving access in areas with limited emergency response. We're also integrating naloxone distribution within community education, treatment linkage, and recovery supports, while expanding partnerships with harm reduction programs, treatment providers, and first responders to achieve and sustain county-level saturation. In addition, we have other key partnerships and programs that we are providing to support a reduction in overdose. One of those is Kentucky continues to work on reducing unsafe prescribing practices. We have worked through our partnership with the Kentucky Hospital Association, the statewide opioid stewardship initiative that certifies hospitals that demonstrate safe prescribing practices and measurable reduction in opioid use. Currently, there's 124 hospitals that are enrolled, and prescription rates continue to trend downward. The program promotes evidence-based prescribing protocols, care coordination for patients at risk of opioid misuse, and routine naloxone co-prescribing for high-risk patients. We are also expanding this work into primary care settings through the 6 building block model. This includes 6 hospital-owned primary care networks representing over 80 clinics that have implemented written prescribing policies, adopted non-opioid pain management approaches, and aligned with federal and CDC clinical guidelines. This initiative emphasizes provider education, patient safety, and ongoing monitoring to ensure long-term reductions in unnecessary prescribing. Another initiative we have is the quick response teams. The quick response is an important part of our overdose strategy. The teams operate in multiple Kentucky counties, and each team typically involves law enforcement, emergency medical professionals, and a peer support specialist. They engage with individuals within 24 to 72 hours after an overdose or near fatal event. Their work focuses on connecting individuals to treatment, recovery supports, harm reduction resources such as naloxone and drug test strips, and care coordination. These teams have been shown to increase treatment linkage rates and reduce repeat overdoses in communities where they operate. Finally, we're also continuing to expand access to evidence-based treatment for opioid use disorder through several coordinated models. We're partnering with university hospitals using a hub and spoke model to stabilize patients in specialized care and then transitioning them to community-based or primary care providers. We have a treatment access program where we provide support for residential or intensive outpatient treatment for uninsured or underinsured individuals. We basically want to make sure if someone's in need of treatment, there is treatment available for them. We have a specialty care partnership that supports patients with complex medical needs. We have partnerships through the federally qualified healthcare centers and rural health clinics where we're integrating substance use disorder treatment and medications for opioid use disorder into primary care settings. In the emergency departments, we have bridge clinics that provide immediate, low-barrier access to medications that are proven to reduce illicit opioid use, cravings, return to use, overdose risk, recidivism, and infectious disease transmission. Beyond treatment, we also continue to advance prevention and stigma reduction efforts to support individuals, families, and communities that have been impacted by addiction.
Excellent. Thank you. Senator Douglas, you have a question, comment?
Yes, Mr. Chairman. Thank you very much. I do have a question. Is there any data about whether naloxone decreases the incidence of overdose? Because there's a misunderstanding that all overdose produces death, and they don't. And we don't talk about the incidence of overdose. We talk about the incidence of overdose deaths. So my question is whether we have the data that suggests it decreases the incidence of overdose, or even those that don't even cause death.
I'm not aware of any.
Okay. Thank you.
Senator Carroll.
Thank you, Mr. Chairman. And Van, thank you, and thank both of you for all that you do. It's crucial, and you all do an awesome job. We had testimony in Families and Children this morning related to pediatric ingestion cases and the growing number of those cases and the inconsistencies throughout the state on response and prosecution. Are there any efforts within your office to address these? And these are death or near death cases, and they are overdose cases that are being reviewed. And I think it's a population that we're not spending enough time on, and if we don't and make some changes, I think the number is going to continue to grow?
Thank you for that question, Senator Carroll. I watched that presentation with Alicia this afternoon. We started partnering with the panel, I want to say 2 years ago, to provide medication lock boxes. So we've done that the last 3 years. As a matter of fact, Alicia is coming in front of our Kentucky State ASAP board to request some tobacco settlement money again this year for that same project. So that's the way we've tried to help, is provide those materials. She's got a good network of folks that help get them out across the state. And we will continue to provide those when needed.
And I like the idea of that overdose response team. It would be nice if that applied somehow to pediatric cases. And it would be more of an immediate support in law enforcement involvement, because sometimes there is just no involvement. And the 2 or 3 cases we heard this afternoon, a couple of those pretty concerning on why nothing happened.
Well, I do participate in a call with the QRTs every month. I'll bring that up the next time we talk about them getting involved with a pediatric overdose.
Awesome. Thank you, sir.
Yep.
Thank you.
Anyone else? Seeing none, thank you for your presentation. Appreciate you being here. Appreciate your patience as we got through our agenda today, but excellent information. Greatly appreciate it.
Thank you for the opportunity. I appreciate it.
Thank you.
That concludes our agenda. You can hold your applause because it's 4:56 in the afternoon. With that, we conclude this interim joint committee on the health services for this interim session. So appreciate everyone's participation and involvement, particularly our staff. They do a fantastic job for us, and can't thank you guys enough for the efforts you put into this, but thank you. But that, ladies